Hello everyone, CardioMinds channel, and we are still in the topic of guidelines of cardiovascular prevention, and today we are discussing risk modifiers. We have discussed in the last video the conventional risk factors for cardiovascular disease, which are already included in the risk algorithms, but there are some pieces of information that may modify calculated risk in individuals, and that's why they are called risk modifiers. In order to consider this piece of information as a potential risk modifier, there are some conditions that need to be fulfilled. First, it improves measures of risk prediction. This means that their presence increases the risk of cardiovascular disease. Also, public health impact is clear and is reflected on the number needed to screen and the net benefit in the reduction of burden of cardiovascular disease. It is feasible to obtain in daily practice via history taking or examination. Also, the information is not just available on how the presence of this risk modifier increases the risk of cardiovascular disease. No, if it is also showing favorable result, it may decrease the risk. And the last thing is that the literature in this potential modifier is not distorted by any publication bias. There are some challenges to determining risk modifier. The first thing is that very few modifiers meet all these criteria mentioned before. Also, some meta-analyses in this field are susceptible to substantial publication bias. This means that they exaggerate the impact of these modifiers on the cardiovascular disease. Also, the exact way to integrate these risk modifiers in the risk algorithms is mostly unknown and may be complex, and there are no enough randomized clinical trials to determine whether the added risk information can lead to improved health outcomes or not. That's why risk factors are not the same as risk modifiers. Risk factors are stronger in their association with atherosclerotic cardiovascular disease, and that's why they are clearly integrated in the risk algorithm. This is not the case with risk modifiers. The question that comes to our mind, are risk modifiers really important in clinical practice? If you are speaking about low risk or very high risk situations, additional information here is less likely to alter management decision. However, the assessment of potential risk modifier is clinically relevant. If the individual's risk is close to the decision threshold, this means that it moves the patient's category from intermediate to high risk or from high to very high risk. But take care that you should not depend on risk modifiers only to increase risk estimates when the modifier result is unfavorable. You should integrate both risk factors plus risk modifier for more accurate risk stratification. The risk modifiers that we are going to speak about today are psychosocial stress, ethnicity, imaging, frailty, family history, genetics, environmental exposure, and biomarkers in blood or urine, and lastly, body composition. Let's start with psychosocial stress. There is clear association in a dose-dependent pattern between psychosocial stress and the development and the progression of atherosclerotic cardiovascular disease, including stress symptoms as symptoms of mental disorders or the stressors themselves like loneliness or critical life events which have detrimental effect on the cardiovascular disease. The relative risk of psychosocial stress are commonly between multiplied 1.2 or multiplied by 2 even. Conversely, indicators of good mental health like optimism and strong sense of purpose are associated with a lower risk. How does psychosocial stress affect cardiovascular disease? It may be a direct biological effect, which was explained a lot in literature, or indirect effect because the stress is correlated with socioeconomic and behavioral risk factors like smoking, poor adherence to medication, or unhealthy dietary habits. All of these will affect cardiovascular disease in a negative way. Vital exhaustion as well is strongly correlated and has been proven to improve risk reclassification, so that's why it is important to detect this abnormal psychological response which may adversely affect cardiovascular disease. The impact of psychosocial stress has been explained in several guidelines and scientific statements, and so it is recommended to screen cardiovascular patients for psychological stress. In a recent prospective cohort study with a median follow-up of 8.4 years, there was favorable effect of screening for depression on the major cardiovascular events. That's why there are some core topics explained in the guidelines this year for psychological assessment, like simultaneous diagnostic assessment, screening instrument to assess depression and anxiety and insomnia like patient health questionnaire, stressors like asking the patient, are you bothered by stress at work, financial problems, difficulties in the family, loneliness, stress events, need for mental health support as well, like referring the patient to a psychotherapist or mental health service, and this is much more explained in the guidelines this year. So there is a clear recommendation this year that stress symptoms and psychosocial stressors modify cardiovascular risk, and so the assessment of these stressors is class 2A as they are reflected on the cardiovascular disease burden. Don't forget the socioeconomic determinants like low socioeconomic status and work stress, which are independently associated with cardiovascular disease development in POL6. The strongest association is with low income, and also there is an association with work stress, which may be caused by job strain or effort-reward imbalance. Let's move to the ethnicity as a second risk modifier with us today. The question that comes in our minds: why does ethnicity affect the risk of cardiovascular disease? The reason for this difference is inadequately studied, and we cannot fully explain why there is some difference in the risk of cardiovascular disease between population of different ethnic backgrounds. But is it relevant? Of course, due to considerable variability in the risk factors of cardiovascular disease between immigrant group, no single risk score can be performed adequately in all groups. That's why it is important to recognize the ethnic background of the individual you are performing risk stratification in. That's why we use a multiplying factor in order to modify the risk of cardiovascular disease independent of the other risk factors included in the risk algorithm. An important note that the impact of country of residence is different from the impact of ethnicity. The impact of ethnicity is related mainly to genetic predisposition, while the impact of country of residence would be reflected through the environmental exposure and the lifestyle. Examples of ethnicities that have modified cardiovascular risk: the South Asians have increased risk of cardiovascular disease. So, for example, in people from India and Bangladesh, the risk is multiplied by 1.3, while in Pakistanis the risk is much more, and so it is multiplied by 1.7. In other Asians, the risk is relatively less, so it is multiplied by 1.1. In Black Caribbeans, the risk is less, so it is multiplied by 0.85, and the Black Africans and Chinese risk is multiplied by 0.7. So these examples show us the effect of ethnic variation on the risk of cardiovascular disease. And there is a clear recommendation in this guidelines that the multiplication of calculated risk by relative risk for a specific ethnic subgroup should be considered. Let's move to the role of imaging on the risk of cardiovascular disease. We all know the role of coronary artery calcium score in the CT coronaries, as it can reclassify cardiovascular disease upwards and downwards with the other conventional risk factor, and so it can be considered in both males and females with calculated risk around decision threshold. And in case of higher than expected coronary artery calcium score, it can increase the person's calculated risk, whereas absent or lower than expected coronary artery calcification is associated with lower than calculated risk. The limitation of coronary artery calcium score is that it doesn't provide direct information on total plaque burden or the severity of stenosis, because some middle-aged individuals may have low or even zero calcification despite having soft non-calcified plaque, which represent a risk for acute coronary syndrome or even STEMI. Also, its extent should be compared with what be expected for a patient of the same age and sex, because there are different ranges between different ages and different sexes. Also, the availability and cost effectiveness of CT coronaries is a big limitation, because not in all communities we can have available CT coronaries. That's why it is not available for everyone, depending on the region in which we are performing risk stratification. When we speak about carotid ultrasound, we always remember the carotid intima media thickness. Does it have a role in risk stratification? Its systematic use to improve the risk assessment is not recommended at the time being due to the absence of added value in their prediction of future cardiovascular events, even in intermediate risk group. However, the carotid plaque assessment is much more important, as it can reclassify cardiovascular disease risk, so it can be considered as a risk modifier when coronary artery calcium score is not feasible. So we have a class 2B this year for coronary artery calcium score to improve risk classification around treatment decision thresholds, and plaque detection by carotid ultrasound can be used as an alternative when the score is not available or not feasible. When we speak about Doppler study, we mention, of course, the arterial stiffness, which is measured using aortic pulse wave velocity or arterial augmentation index. It was having a role that it predicts future cardiovascular risk, but the measurement difficulties and substantial publication bias argue against their widespread use in the risk stratification. We know the famous ankle brachial index, which is already known since we were undergraduates, that it has a role in the diagnosis of peripheral artery disease. The surprise that in 12 to 27% of middle-aged individuals who are having an ankle brachial index less than 0.9, 50 to 89 of them don't have typical claudication. And an individual patient data meta-analysis concluded that the reclassification potential of ankle brachial index was limited, with the exception of women at intermediate risk. That's why there is no rule for the routine use of ankle brachial index for risk stratification. Regarding the echo, does it have a role in risk stratification? Of course, it has a role in the diagnosis of cardiovascular disease in symptomatic individuals, but due to lack of convincing evidence, there is no role that echo improves cardiovascular disease risk reclassification, and that's why it is not recommended to improve cardiovascular risk prediction. Let's move to the fourth risk modifier today, which is frailty. Frailty is a multidimensional state that is independent of age and multimorbidity, but it makes the individual more vulnerable to the effect of stressors, and it can be considered as a functional risk modifiers for unfavorable outcome, including cardiovascular and also non-cardiovascular morbidity and mortality. But we should emphasize that frailty is different from aging, because the incidence of frailty may increase with age, but we can find people of the same chronological age and they are completely different in regarding health status and vitality. Even you can find someone who is younger but he is frail, and we can find an older one who is not frail. This shouldn't omit that the biological age is still important in the context of clinical status and hard clinical outcomes. Because we consider frailty as a risk modifier, its screening is important in every elderly patient, especially when being at risk of accelerated aging, and most of the screening tools related to frail features including slowness and weakness, low physical activity, exhaustion, and shrinking. And because during an acute event the frailty assessment is more difficult, it can depend on history taking of his previous condition or can be postponed after the patient returns to his stable condition. So we can mention that frailty has two clear impacts. Impact on cardiovascular disease risk, which include people with atherosclerotic cardiovascular risk factor, subclinical cardiovascular disease, stable cardiovascular disease, acute cerebral or coronary syndromes, and heart failure. And here the frailty itself, rather than the classical risk factor, can predict both all-cause and cardiovascular mortality in the very old people. However, the ability of frailty measures to improve risk prediction has not been formally assessed. That's why frailty measures are not integrated in the formal risk assessment or risk algorithms. The second impact is on treatments, and here we are speaking about two important factors, which are polypharmacy and comorbidities in frail individuals, making them more susceptible to drug side effects and serious complications during invasive procedure. So we should know that frailty assessment is not a method to determine the eligibility for a particular treatment, but rather to make an individualized care plan with predefined priorities, as here we can expect the benefit-risk ratio in this frail individual. Let's move to a famous risk modifier that we all believe in its clinical relevance, which is family history. A famous quote in the guidelines this year is that family history of premature cardiovascular disease is a simple indicator of cardiovascular risk, reflecting genetic and the environment interplay. This quote can summarize the effects of family history on cardiovascular disease. And when we speak about family history of premature cardiovascular disease, we mean that there is a male member in the family, usually first degree, affected by cardiovascular disease at the age below 55, or a female member affected below the age of 65-year-old. And cardiovascular disease, of course, means atherosclerosis in any vascular beds, not only coronary artery disease. However, we should mention that family history only marginally improves the prediction of cardiovascular risk beyond the conventional risk factor. This is because of the varying definition of family history applied, and because major risk factor may explain the impact of family history. Despite this, still family history of premature cardiovascular disease is extensively assessed in history taking because it is simple, inexpensive step that can trigger comprehensive risk assessment. Genetics have a controversial role in the risk stratification. There is lack of consensus regarding which genes or corresponding single nucleotide polymorphism which can be included in the cardiovascular disease risk, and whether to use risk factor specific or outcome specific polygenic risk scores. That's why there is no validation about their use in risk stratification. Also, the polygenic risk score have shown potential to improve risk prediction for primary prevention, but their prediction accuracy is still a matter of controversy and needs further evaluation. Environmental exposure is usually one of the risk modifiers that are omitted in the clinical assessment. We mean by environmental exposure that modify cardiovascular risk: air pollution, water and soil pollution, and above threshold noise levels. The hazards of environmental exposure are shown that all are associated with multiple cardiovascular disease outcomes, including fatal and non-fatal events, and the recent model estimated that loss of life expectancy due to ambient air pollution is similar to that due to tobacco smoking. And on the contrary, reduced exposure to particulate matter and to pollution is associated with improvements in inflammation, thrombosis, and oxidative stress. And this is of course reflected on the reduced burden of cardiovascular disease. That's why there is a Class 2B recommendation in these guidelines that patients at very high risk for cardiovascular disease may be encouraged to avoid long-term exposure to regions with high air pollution, and in regions where people have long-term exposure to high level of air pollution, opportunistic screening program may be considered. Urinary and blood biomarkers have a controversial role in the risk stratification. They may reflect either a causal relationship like lipoprotein A, which is a famous pathogenic lipid fraction, underlying mechanism like C-reactive protein, and cardiac affection like BMP and troponin. In the 2016 European Guidelines of Cardiovascular Disease Prevention, they recommended against the routine use of biomarkers because they don't improve risk prediction, and publication bias seriously distorted this evidence. This is the same recommendation in 2021 EC guidelines, so there is a big no for the routine collection of potential modifiers that don't have evidence of strong role in risk prediction, like genetic risk score, circulating urinary biomarkers, some vascular tests or imaging except coronary artery calcium score or carotid ultrasound for plaque determination. So we don't use routine echo, routine assessment of carotid intermedia thickness, assessment of arterial stiffness, or assessment of ankle brachial index. The last modifier we are going to speak about is body composition. We spoke before about adiposity, and we mentioned that there is a linear relationship between body mass index and cardiovascular mortality in non-smoker, and it is a J-shaped relation in ever smoker. We also mentioned that the optimal body mass index to reach is 20 to 25 kg per meter square with the lowest all-cause mortality. We discussed the body mass index and waist circumference, which are strongly correlated with the risk of cardiovascular disease, and also we mentioned the phenomenon of obesity paradox. When we speak about body composition, which index of obesity is the best predictor of cardiovascular disease risk? We mentioned the body mass index, which is easily measured and widely used, but also we need to comment on the body fat, which is stored in visceral and ectopic depot, and it carries a higher risk for cardiovascular disease than subcutaneous fat. And waist circumference, of course, is the simplest way to assess this abdominal fat. The cutoff point for waist circumference is nearly the same as in the last guidelines. Waist circumference more than 94 cm in men or more than 80 cm in women needs no further weight gain, whereas in waist circumference more than 102 cm in men or more than 88 cm in women, it needs advice for weight reduction. And so comprehensive risk assessment should be considered in individuals with adiposity or unfavorable body composition like the apple-shaped obesity, for example, because they are associated with risk of hypertension, dyslipidemia, insulin resistance and followed by development of type 2 diabetes, systemic inflammation and prothrombotic states, albuminuria and decline in GFR, cardiovascular event, and atrial fibrillation. So not only the adiposity is important, but also paying attention at the body composition and the waist circumference. So we have discussed today these risk modifiers. Some of them strongly reclassify the risk of cardiovascular disease, and some of them have weak evidence due to a lack of sufficient trials. So our take-home message today is that the risk modifier may have less clinical impact on cardiovascular disease risk reclassification than the conventional risk factor, but they shouldn't be omitted during clinical assessment because they put the individuals at a relatively higher risk, and so we need to integrate both risk factors and risk modifiers. Thank you very much for watching this video, and wait in the next video for the clinical conditions associated with cardiovascular disease risk.